Okay, so this is starting today's presentation. We're going to talk a little bit about the basic principles of ultrasound. So in particular, how an ultrasound machine works, how the probe works, but then a little bit more about ultrasound physics, and then really how ultrasound physics applies to the generation of images of lung when we use lung ultrasound. So as we know, an ultrasonic wave refers to a wave with a frequency over 20,000 hertz. So it's actually beyond human hearing range. But really, these ultrasound waves, when presented to the human body, can actually interact with tissue. And with a transducer placed in appropriate place, when the human body is scanned, the emitting sound waves spread into the tissues and basically reflect back. So really, if I put an ultrasound machine connected to an electrical source, it's got piezoelectric crystals in it, which basically generate these sound waves. The electricity is converted into them, which then basically interact with tissue. And really, once they interact with tissue, they reflect back, and the ultrasound machine interprets these to generate an image. And this really, whilst it's a very simple process, is a little bit more complex in that depending on the nature of the probe you use, whether that's a sector probe, whether that's a linear probe, or whether that's basically a curvilinear probe, you will get different image characteristics based on the interaction with tissue. And in particular in neonates, depending on the probe you use, especially if you're using it for the purposes of lung ultrasound, there can be significant variations in how the image is actually presented to you, which can affect interpretation. Now, traditional models of ultrasound basically rely on this concept, which we call the piezoelectric effect and the reverse piezoelectric effect. But the intention from our perspective is that whenever we hold an ultrasound probe, we try to keep it as perpendicular to tissue as possible, because any sound waves that are generated then interact with that tissue and reflect back. And the ultrasound, as I will tell you, kind of makes an assumption that when it's sending those waves out, those waves interact with tissue in a certain way and come back. So it makes its interpretation and basically generates an image. But really, what I would say is the way the ultrasound waves interact with the tissue don't necessarily conform to the rules that the ultrasound probe and machine apply. They interact in very different ways, in a variety of different ways, which then results in what I would say is the image of the tissue and sometimes results in artifact. An artifact is actually something that you don't actually see. It's visible, but it doesn't actually represent anatomical tissue. It's more like a mirage. Now, what does that mean for us? So, really, when you kind of look at ultrasound, uh, you're interpreting tissue, you're interpreting anatomy, but in certain situations, actually, it's particular the lung, because there's an air interface and there is predominantly artifact that is visible, we have now generated patterns with the artifact to kind of recognize normal, abnormal, and various pathological states, which is related to the air and water content of the lung. So really, when we're looking at lung ultrasound in particular, what we're interpreting is not necessarily tissue, but actually artifact. In certain situations where fluid becomes excessive or lung tissue gets damaged, the ultrasound waves can interact to then interpret tissue. But it's all a play of frequency and wavelength. Now, this is a very, very important concept. Normally in neonates, we tend to use frequencies of anywhere between 8 up to 15 when we're doing lung ultrasound. And that's quite a range. And that's because naturally neonates are smaller than adults. If you look at adults, the frequencies used are lower. They tend to use curvilinear probes. We tend to use linear probes or hockey sticks with a higher frequency. Now, why is that the case? Well, to understand that, we first have to understand what is frequency, what is wavelength. And this is a very, very important concept. Now, when a person claps, so you can see the gentleman over here, when he claps, he generates sound waves. And these sound waves basically will travel, they'll hit a brick wall, and you will hear the echo back. And this is pretty much what is happening with an ultrasound machine. Now, if he claps once, naturally one sound wave travels and it comes back. Now, if he claps repeatedly, then what we find from our perspective is that you will generate sound waves at a certain interval. The generation of sound waves at that interval, basically from our perspective, is known as frequency. So this is generating a sound wave. Now I'm actually generating a frequency of sound waves, multiple sound waves at a certain frequency. This is a higher frequency. This is a lower frequency. So from my perspective, this is frequency for you. What is very important from our perspective is that frequency will travel a certain distance. And this distance is what we call wavelength. Now, depending on factors like attenuation, like the tissue which is interacting with this sound wave, naturally the frequency will determine how much we can penetrate this tissue. And this concept, again, is very important for us to understand why we use higher frequencies with linear probes in neonates as opposed to using lower frequencies with curvilinear probes in adults. You can actually use them in neonates as well, but you then need to know the fallacies of being able to use them. So I hope you understand the differences between frequency and wavelength. Uh, why is this so important? So I'm just going to give you an example that when you use a higher frequency, what happens with sound waves is they tend to travel a smaller distance. So if you look at this, this is a higher frequency. So my apologies. So this higher frequency, let's assume that we have a probe. So I'm just going to draw over here with my laser pointer. So let's assume you have a probe, and this probe is basically generating sound waves. Now, naturally, if it's generating sound waves at a higher frequency, as you can see over here, the sound waves are closer together. So the actual distance that they travel is much shorter than if you use a lower frequency with less sound waves per second, which kind of means that because there are fewer sound waves, they're further apart. And that just means that if you actually look at the wavelength they're able to travel or the distance, they travel a longer distance. Now, this applies to probes as well, because clinically, from our perspective, if you use a high frequency ultrasound probe, 8 hertz, the sound waves will naturally travel a shorter distance. Now, if they travel a shorter distance, they will be superficial, and we'll be able to interpret superficial tissues better. On the other hand, if you use a low frequency, it will travel a greater distance, which means greater depth, which means it can penetrate tissue and we can see deeper. But as I will explain to you, the ability of those sound waves to then interact with the superficial tissues becomes less, and you get resolution that's not so good. Hence, if I have a preterm baby who's got a very superficial lung with very little tissue interface in between, ideally I want to see the superficial structures. So I will use a higher frequency probe. Whereas if I have a term baby who has tissues that are deeper, I might need to go to up to 5 centimeters to actually see the lung in its entirety. I will use a low frequency probe because it can travel a greater distance. But the resolution that it will give me for the superficial tissues will actually be not as good. And it just means that I might then have to adjust certain things like focus or the frequency to try and better my image. And we will do a lot of that when we do our peer reviews. Now, in essence, this is the process of interaction of sound wave with tissues. And the reason I want to take you through this is basically to explain to you how the image is generated. So when you look at an ultrasound probe, so this is basically our probe. This is generating sound waves. Now, the assumption that the ultrasound probe makes is that from our perspective, these sound waves are going to travel in one direction and they're going to come back through a process called reflection. This probe will then interpret these sound waves and convert them into an anatomical image. It also makes an assumption that whatever tissue is passing, it's passing through, these sound waves are interacting with, is uniform. It's one density. So actually the sound waves should interact with that tissue in a uniform manner and come back to us so that we generate an image which is of a certain consistency and quality. But actually, what we know is that when we generate sound waves using the ultrasound machine, we tend, from our perspective, to have a variety of different things which basically interact with the sound waves. And this could involve reflection, it could involve refraction, it could involve absorption of the sound waves with the tissue. And all of these things, whether that's refraction, absorption, results in dissipation of energy of sound waves, which means that the way they interact with the tissue will be varying. More importantly, tissue density will change. And I mean, if you look at this is the left ventricular cavity. This left ventricular cavity at this particular point has got a ventricular wall with an outer wall and an inner wall, and it's then got a very hypoechoic area, which is basically fluid. Now, as I will discuss the properties of sound waves with you, naturally, the difference in acoustic impedance at this level, where sound waves are traveling through tissue, which is of a lower density as compared to tissue of a higher density, is very high. So actually, you reflect back a lot of sound waves from the superficial area, which gives you this bright image, which we tend to call kind of, I would say, hyperechoic. On the other hand, if you look at the superficial tissues, because the sound waves interact, but there's not much reflection, they're echolucent, but not necessarily hyperechoic. But as soon as these sound waves penetrate into the left ventricular cavity, there's fluid over there. And fluid basically allows the propagation of sound waves in a very uniform way without much reflection. And for that reason, actually, the fluid actually appears anechoic. And then when the sound waves then hit the left ventricular wall, again, which has a higher density, there's a difference between the acoustic nature of the fluid and this wall, which we call acoustic impedance, that I will explain to you, causing further reflection. Now, for the waves that are incident perpendicular, the reflective qualities are good and you see bright areas. But if you find waves that are traveling in, I would say, an angle that's not perpendicular, they tend to interact with the tissues. They refract, as you can see over here. They reflect in a slightly different direction rather than at 90 degrees. And hence you can see the characteristic of tissues over here is less bright as compared to the characteristic of tissues here and here, because the probe is basically sending waves that are perpendicular. You can also see that the intensity of this wall is much brighter than the intensity of this wall, because sound waves have had to pass through this tissue, they get absorbed, and they undergo attenuation. So basically what this results in is an image which at the moment is demonstrating anatomy to you. So we've not talked about artifact, we've just talked about anatomy. And this is how ultrasound images are generated. But I've used a lot of terms, and what we're going to do is we're just going to talk a little bit about the terminology that we're using. Now, as I've kind of described to you, sound waves tend to travel in straight lines from the transducer. The transducer or the ultrasound machine then assumes that the central movement of sound waves will reflect back to you in a central axis so that the image is uniform. It also assumes that the sound wave that is reflected back to you with an elevational direction. So as you can see in the previous image, the sound wave basically moves forward, reflects back in an elevational direction, basically follows the lowest path or the path that is shortest. It forms the central axis of the sound beam. Now, this is thin, this is in a certain direction. And really what it assumes is that depending on the density and the frequency of the kind of waves you set out, this reflection will give you a certain intensity. It will give you a certain echogenicity. But it always assumes that the distance, it also assumes that the distance that it travels through tissue is the same, you know. So it's throwing sound waves at a certain velocity, maybe 1500 meters per second. It makes the assumption that passing through this tissue, that velocity will remain constant. And that from our perspective, the last pulse takes a longer time to come back to it. So there are certain assumptions that this machine makes. What we know, as I have described to you in the interaction of sound waves with the heart, is that actually there's a lot of other stuff that happens rather than just simple reflection. So there is what I would call is scattering of sound waves. So you might have tissue, and tissue might have individual cells in it, and these cells will interact and they will trap sound waves so that the sound waves reflect infinitely within the tissue, or they will reflect sound waves, and that reflection necessarily won't actually go back at 90 degrees. It'll go all over the place. And it just means that if you're looking at the liver, say, for example, where you have tissue as opposed to air being in an interface, you're able to get a good kind of an understanding of liver architecture, echogenicity. So if you have an extravasation in the liver with something that has calcium in it, that'll be bright, and that'll kind of interact in a bright way, and you'll get an echo bright area in the liver. On the other hand, if the tissue is uniform and pretty much nothing bright is there to kind of reflect back, you can kind of get this, I would say, hypoechoic appearance to the liver, but you can see its texture because of this concept which we call scattering. Now, naturally, as the wave goes through, the machine assumes that it's going through at a certain velocity, which it's constant. But the fact is, the waves basically go through a variety of different tissues, from skin to pleura to soft tissue. There's fat in the soft tissue, which changes the velocity. And in this process, while the velocity changes, the tissues also cause problems with absorption of the energy of the waves, which means that the waves become less energetic, they become less intense, and they then interact with tissue in different ways as they move through the tissue interface. But whilst absorption is taking place, what is happening to the sound wave is that it's also getting weaker. And as it passes through deeper tissue or certain kinds of tissue, because of the issues of reflection, and bone is a very good reflector, it'll just reflect everything back, the energy dissipation uh, will in tissue be higher. And this concept of loss of energy and the waves becoming weaker as they enter tissue after the process of reflection has taken place is called attenuation. Now, a lot of what I'm describing to you at this particular point, and I'm being very slow, and you might kind of feel, well, this is very boring stuff. Why do we need to know this? It's because you need to understand how the image of the normal lung is generated and then how we interpret the abnormal lung. Last but not least, we have a kind of a phenomenon which we call refraction. So we assume that sound waves from a transducer basically are incident at 90 degrees, but the fact is they're incident at 90 degrees only if your probe is actually aligned well. So if I just draw for you what I mean by that is if my probe is aligned at 90 degrees, naturally my sound waves are going to hit at 90 degrees. Now, this is assuming this probe is a linear probe. If it's a convex probe, rather than actually hitting at 90 degrees, the waves move in multiple different directions. Now, naturally, if they are incident at 90 degrees, they will, assuming the tissue is uniform, go straight. But actually, if you have a difference in density between the two tissues, what we know is they can refract. But what makes it even more difficult is if you're using a curvilinear probe where the waves are moving out in different directions. Not only will they move in different directions, they will refract in different directions because of the difference in density of the tissues. And this concept is called refraction. But again, you can see how the nature of the probe is then going to basically interact with the tissue underlying you to give you images that can actually vary. Not only do they vary, but they then can affect your interpretation. And that's why it's very important that you understand the fallacies of using different probes, something that we will discuss a lot when you're doing your peer review. So before I move on to what is happening at the level of the lung, I'm going to break just to ask questions. So the way that you would ask questions is you can put them in the chat, and we do this every 20 minutes. So really, any questions? Okay. Anybody can put the hand up as well. So I want everybody to write yes in the chat box to say that they've understood the basic principles of how an image is generated, that they understand the concept of frequency and amplitude. These are the two most important objectives from these initial slides. If you have not understood this, then I need to go through this again. And I cannot emphasize enough how important this is. Okay, everybody seems to have understood it. Okay, excellent. Now, just we're going to cover this in a lot of detail, but I just want to give you an idea of what is happening at the surface of the lung when we talk about these different concepts like reflection, scattering, absorption, attenuation, and refraction. And a very good way of looking at this is basically looking at a probe. Now, this is a sector probe that we're using at this particular point. And when you look at the sector probe, there are sound waves being generated that are coming into the tissue. Now, naturally, what have you got? You've got skin, you've got soft tissue, you've got muscle. If for those of you who put chest trains, remember, you then have ribs, naturally muscle in between the ribs, and then you have pleura. And distal to pleura, you have alveoli, and these alveoli are basically full of air. So whenever a sound wave basically interacts, it will go straight, naturally it'll reflect off the ribs, it will also reflect off the pleura, come back, and really we'll get an interpretation. Some of these sound waves will scatter, they will scatter off, they'll reflect back, and really they will reflect back off rib much more because bone tends to be a very good reflector, creating a kind of a posterior area where sound cannot necessarily penetrate. So this is kind of a dark area. And this is what we call acoustic shadow of the ribs. But more importantly, not only will they interact with the pleura, but they'll have an attenuation effect as they interact with the pleura. They'll then interact with tissue and they'll further attenuate. And really, what I'd say is that if you're using a frequency that is relatively low, it will penetrate deeper. But because it will have to interact with a lot of tissue, it will attenuate. And for that reason, what happens is you can see the deeper part of the areas with the probe that has a lower frequency, but actually its resolution will not be so good. We will cover that concept again. But just to say, you can see how reflection is happening. You can also understand why there'll be scattering because of tissue and alveoli at this level. Naturally, if there's fluid at this level, that fluid will cause even more scattering. And it causes scattering to the point where the sound waves basically get stuck in the fluid bubble, tetrahedrons, infinitely. And that causes what I will show you is the formation of A, B lines respectively. So if there's air, it's A lines. We'll talk about that. If it's fluid, it's B lines. More importantly, from our perspective, as attenuation takes place, you can just see that as you move deeper, these these lines, these horizontal lines called A lines become less conspicuous. And this is happening both because of absorption of the sound waves with the alveolar tissue, but also because of the phenomenon of attenuation. But really, for incident sound waves which are perpendicular, this area is brighter. And actually, this area is not so bright because actually what is happening is you're having less reflection for incident sound waves because the probe is not perpendicular here. It's curvilinear. So actually this area is well, has got good resolution. This area doesn't have such good resolution. And more importantly, as you move in, because of refraction, you have sound waves that are not interacting as well over here. So you have acoustic shadowing, but necessarily you can see how there are certain areas that don't actually show up so well. Now, that is kind of because of all these phenomena that are taking place. Okay, so I've got Fuad who's raised his
Yeah,
hand. Yeah,
just I have a comment. Could you use the cursor, please? Because
yeah,
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 thank you.
no problems. So I can use the cursor. So just again, going through that concept. So your probe basically is generating sound waves. Those sound waves are basically moving in a fashion, if the probe is aligned properly, perpendicular to the tissue. Naturally, it aligns best with tissue that has good reflective surfaces and reflects back. Now we know that bone has a higher density, so a much higher reflectivity, which kind of means that there's going to be less sound waves going in here. So naturally, behind the bone, because you have less sound waves in there, you're going to have this phenomenon of an acoustic shadow. But more importantly, from my perspective, you are also going to see reflection, which is poor at the margins because the waves are incident, not at right angles, but in a much wider way. Now, as they interact with the alveoli, you'll have this phenomenon of attenuation, of absorption. And you can just see that these A lines become less conspicuous as you go in. And it's because the sound waves essentially are becoming weaker. Some of the energy is being absorbed, but the sound waves are also getting attenuated by interaction with the tissues. And then you have refraction, again, where the sound waves basically, rather than being incident, parallel, and coming back to the probe, and this is a curvilinear probe, they're going through tissue. Sorry, this is sector probe. They're going through tissue, they're interacting with pleura, and then at the pleural interface, which is solid, you suddenly move from kind of a soft tissue interface to a pleural interface. And these sound waves wouldn't necessarily be perpendicular, they'll refract. And that's why you get the slight difference in echo texture. So you can see the A lines are pretty prominent over here. They are not so prominent over here. And some of this is the acoustic shadow of the rib, but some of this is also refraction. So in essence, you can see how all of these kind of phenomenon are contributing to the generation of images. Any doubts so far? Any queries? Feel free to put your hand up. Okay. Now, how do the principles necessarily apply to lung ultrasound? Now, we basically have to talk about acoustic impedance before we actually discuss how this interaction takes place. And this is a very, very important concept. Now we know that, and I'm just going to go back to my previous slide, that you've got multiple interfaces when sound waves are incident on the lung. So they will pass through skin, they will pass through soft tissue, which has fat, fascia. They will then pass through muscle. There will then be pleura. Pleura, they will then have alveoli below that, and those alveoli basically will have air within them. And really, there is a difference between the density and the velocity with which the sound waves will travel through these different areas. Now, this concept basically means that from our perspective, we have different levels of acoustic impedance between the different areas of the lung. And this is a very important concept because the essence of generation of echolucent images or bright images is reflection. And if you have a significant difference between the density velocity with which waves pass through different areas of the lung, that is, i.e., difference in acoustic impedance, you will have more reflection. And that reflection will then give you an echo bright appearance. Now, this concept of acoustic impedance can be demonstrated here. So what you've got is this is a curvilinear probe that's being used at this particular point. So you can see that sound waves will be incident in different areas. And if you look at the different tissues over here, so you've got basically skin right at the top. Now, if you were to use a probe without putting any gel inside it, there'd be air between that interface. And what you'd get is very poor images. So to allow sound waves to penetrate better, we put gel on the probe at skin to allow the sound waves to penetrate through the skin and then through the soft tissue, which is happening over here. Now, the density of skin and soft tissue is going to be very different to the density of what is a very large cyst which has fluid in it. And this fluid basically also has exudate with these areas of exudate that you can see. So when sound waves basically pass through it, naturally, we talked about the fact that if you have differences in density and velocity with which sound waves travel in the soft tissue versus an area that has a lower density, so this might be higher density, then really from our perspective, what you're going to get is a lot of reflection back. And that's why you can see that this area of soft tissue is echo bright. But actually, once it enters fluid, fluid has a relatively uniform density. So actually, if you look at the fluid here, the entire area that you see, and I'm just going to draw it out with my pen. Doesn't want to play ball with me at the moment. This because I'm using the same color, just use a different color. So really, the echolucent kind of appearance that you get over here is because the sound waves are traveling in one direction without actually any difference in the density with a uniform velocity. So actually, they're not reflecting back. And hence, you get what is kind of an hypoechoic area here. You get a slightly lucent area here, but the difference in density between these two causes a lot of reflection back, which gives you this echo bright area. And then suddenly these sound waves hit the back wall of the cyst again, and they will reflect back. But as you can see, as they reflect back, naturally having traveled through all of this, they've lost energy, there's been absorption, there's been attenuation. So actually, if you look at the upper part of the cyst, it's very bright in the soft tissue area. It's not as bright over here. It's even less bright over here because actually the sound waves traveling directly will have more energy. But for sound waves traveling in this direction, they're going to have to pass through more tissue. They will interact with this, they will refract, they'll get absorbed. And this is basically what is producing what is called a cis sign over here. So again, just the concept of difference in acoustic impedance, the greater the difference in acoustic impedance, the more the reflectivity. Now, if you look at tissues that have very high acoustic incidence, so simple example is bone. So it has a very high density. It has uh, a very high velocity of propagation, but that's only if sound waves can get into bone. The biggest problem is that if, say, for example, you have a situation where you have bone and sound waves have to travel between this tissue and bone, then really what is going to happen is the difference in acoustic impedance between this tissue and bone is going to cause a lot of reflection back. So we know that if there's a significant difference in the acoustic impedance between two tissues, there is a lot of reflection. And if there's a lot of reflection, not much is going to basically pass behind them, which is gonna produce these dark areas that you see over here, which are basically acoustic shadows or rib shadows. So acoustic impedance is very important. Now, naturally, if you had bone in contact with skin, say, for example, and you were in a situation where there was not much soft tissue, then the acoustic impedance would not be very significant. And what you would then be able to see is very uniform shadows for bone, again, with less reflection. But it's very important to understand this concept of acoustic impedance because actually it is responsible for reflection, and reflection is the principal diagnostic imaging principle. So the more the reflection, the brighter the image, and that's really what is producing an image. What is very important is reflection occurs when there is significant impedance mismatch, and those surfaces will appear echo bright. Now, as I've said, and I will summarize, having gone through that before I ask questions again, is that if you look at the interaction of sound waves with the lung, there are multiple interfaces. So there is skin, there is soft tissue, fascia, there is muscle, there is then pleura, and below pleura there is air in alveoli. There can actually be air within visceral and parietal pleura, and we'll discuss that when we talk about pneumothorax, what happens to the ultrasound physics in that particular situation. But really, what I would say is that if you use a probe and you don't put any gel, there's going to be an air interface over there, and actually sound waves are not going to penetrate. So your image quality is going to be very poor. But when you put gel there, the sound waves penetrate, they interact with the tissues, and that is kind of the reason between why we put gel in, because really what we want to do in that particular situation is we want to decrease the difference in acoustic impedance between the probe and these tissues to allow sound waves to enter into the tissues. Once the sound waves penetrate into the tissues, they will interact with all of them. There'll be differences in acoustic impedance. And I told you that this is fat over here. Uh, with the fat, there'll be a high velocity of transfer. And the waves will pass through because the density is relatively uniform. The velocity will be uniform. But as soon as you hit the pleural surface is a solid structure, and that'll cause reflection back. So the pleura is basically a very high reflectivity zone. And if you look at the pleura, because of us using a linear, so this is a linear probe being used, all the sound waves are hitting the pleura in a very uniform way, which gives us this uniform linear appearance, which is bright. Now, because the baby breathes and there's air between the lung going in and out, this pleura basically moves on itself, the visceral and the parietal pleura. There's fluid in between, which is usually not visible. And this is basically called lung sliding. And that, in essence, is how a normal lung ultrasound image is generated. When you get fluid, and I'm going to talk about this in more detail, you suddenly have sound waves that have to interact not just with the soft tissue, pleura, and air, but they bounce off these fluid particles, which are organized in tetrahedrons. And that basically disrupts the horizontal reverberation artifact and gives you this B-line appearance. We'll talk about it in more detail. I'm not going to cover consolidation at the moment. We're going to do it towards the end. Any doubts? Any questions so far? So can I just have a show of everybody saying yes to you've understood how sound waves interact with lung tissue? Is there anybody who hasn't?
Yes.
Okay, anybody who hasn't, I'm happy to go through it again. It's a very important concept. Okay, I will take that as yes for everybody. I'm just going to go through the chat to see if any questions. Yes, 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 yes. Okay, lovely. Amazing. Okay, so we'll go on to the next part now. So again, just the concept of applying gel just to improve and reduce your acoustic impedance. Now, we've covered a lot of this, but what we're going to do is talk about this in a little bit more detail. So basically, what is attenuation? As you can see, attenuation basically means that sound waves that are incident with, and this is pleura, say for example, or kind of as they move further down, they lose energy naturally because we're using a certain frequency and sound can only travel a certain distance in wavelength. Now, if you're using a high frequency, naturally, a high frequency will be able to travel a shorter wavelength. So what will happen is this wave will get attenuated and the image basically that's visible deeper will be less well visible because there's less reflection back. There'll be absorption. And again, this is another concept, an important reason why deeper tissues may be less visible and why you might need to reduce the frequency of the probe you're using in order to get better depth because you want the sound waves to travel a longer distance or wavelength. We've discussed reflection, scattering, and refraction. So I'm not going to cover them in great detail, but attenuation is a very important concept. And what it basically means is that sound waves that are generated by the ultrasound probe, not only will they be reflected by tissues, but they will interact with the tissues. Now, when they interact with the tissues, the areas that have less attenuation, the interaction with tissues will be better and the resolution of those images will be better. So if you're using a probe with a higher frequency, we know it's going to travel a shorter distance. And because it's going to travel a shorter distance, there's going to be lower attenuation. And because there's going to be lower attenuation, naturally those sound waves will be able to interact with the individual tissues much better. And they will give you better resolution. So if I take an extremely preterm baby, really what I want to do is see very superficial areas of the lung. So I will use a very high frequency probe because I want to make sure that attenuation is minimum and those sound waves can interact with the most superficial areas of the lung, especially if I want to see pleural sliding. So my frequencies when I interact and do ultrasounds with extremely preterm babies will be 12 and above. On the other hand, if I've got a term baby, actually what I want to do is see tissue that's much deeper down that has to travel through much more superficial tissue, skin, fat. And really, what I would be using is a lower frequency probe so that the wavelength traveled by the probe is higher, so that I can actually see deeper into that lung tissue. And that's why attenuation is such an important concept. Now, what is important from our perspective is that naturally attenuation, depending on the tissue you're going through, will be more. And I mean, a simple example that I'll give you is that if you have more reflection, less sound waves penetrating. Sound waves penetrating into this region from here will have more attenuation behind bone, as opposed to be interacting with tissues because of the density of bone. So again, just another reason why you tend to get an acoustic shadow behind bone. But this is the most important concept that you will take home from me today. And that is the concept of why we use different frequencies for term and preterm babies. But more importantly, when you're using newer machines these days, there are machines that you have to alter the focus in to be able to see the superficial areas. Like in the cranial ultrasound, you tend to alter the focus to the level of interest. You know, if I'm trying to look at a more superficial area, I'll change my focus. But actually, if you're using the new GE machines at this particular point, they have multiple areas of focus which optimize resolution. And really, to kind of look at the deeper structures better, what you'll have to do is reduce the frequency. So, unlike in older machines where frequency used to remain constant, and a simple example is if I'm doing a head scan, I'm basically using a curvilinear probe. You know, my frequency is about 8 hertz. But actually, when I'm doing a lung ultrasound in a term baby, say, for example, I might start with a frequency of 8, which is giving me better penetration, allowing me to see the deeper structures. But actually, if I then want to concentrate myself on the pleura, and I'm using a GE machine where the focus is at every level, I might just increase my frequency to see the pleura much better, give me a better image, a crisper image of the most superficial structures in that baby. I might even increase gain. But what this graph demonstrates is that if you use a low frequency probe, now this is a 1 megahertz frequency that's traveling through soft tissue, for the same distance traveled, it will have an intensity. Now, as the frequency increases, what happens is that the intensity decreases. That's attenuation for you. And that basically means, from my perspective, that the deeper structures are less well visible if you use a higher frequency. Okay? And I'm going to ask again, is is everybody clear about that? Is there any confusion? Anybody? You guys are extremely bright. I must confess, I am this concept when I started learning ultrasound 12 years back was something that just did my head in. And when you look at this graph, people get really confused by it. So really just remember that this is the x-axis, this is the y-axis in negative. So actually, can you see how as you move down, the intensity of the wave will become less with the higher frequency? And this is the phenomenon of attenuation for you. Uh, Babin Seva has asked a question about, can you explain why we see A and B lines simultaneously? And I will explain that. We're coming to that. So just a few more minutes and we will get there. Okay, we'll go to the next slide. Now, as I said, and I've summarized this now, that really for more preterm babies, really what we want is to use a higher frequency because we want to see the superficial areas. Naturally, the wavelength that will be traveled will be less, but more importantly, the interaction of the sound waves with those superficial areas will be better, meaning you get better resolution. On the other hand, if I think about a term maybe, I might use a lower frequency, 8 to 9, because actually sound waves have to go through a deeper amount of tissue, a larger amount of tissue to actually get to the zone of interest. What is also very important is that sound waves, when they hit bone, will reflect back, and that the areas or behind bone, behind ribs, behind the scapula, will really give you very poor information because of acoustic shadow. Now, this is very important, and I'd like to look you to look at me in the screen. So a simple example from my perspective is if I'm holding a probe in the rib area and I'm trying to do an ultrasound, we have scanning that is vertical and we have scanning that is horizontal. And really, when I'm doing vertical scanning, just remember that I'm scanning multiple areas of ribs which are going to give acoustic shadows. But when I'm doing horizontal scanning, I need to be in between the rib areas because if I'm behind a rib or if the scapula comes in at the back and I'm trying to do horizontal scanning, really, I'm going to get nothing. I'm going to get zero. zilch. And it's going to create a lot of confusion in my mind because, especially when I'm starting out, I may not understand that. But I also want to explain to you a simple example. And I want you to look at me in the screen. So if you're using a linear probe, and this is your probe, so you can see that this is the probe, and this is the linear probe that's going to give you sound waves. Now, a simple example is that if this has to be applied to tissue and you don't have it applied in entirety. So a simple example is if this is the probe face, then from my perspective, if this probe is lifted, there is suddenly going to be problems with air between the interface. If it's completely lifted or you don't have good apposition, there's going to be air within the interface. And it is a very common reason why often people end up seeing a barcode sign when the lungs are completely normal and they think they've got a pneumothorax. And the problem is you just don't have good alignment, but it's going to give you very poor image quality as well. So again, what you want to do is make sure that your probe is always aligned at 90 degrees and in good surface contact. Now, where does that become a problem? So if I'm in the axilla and I'm trying to do a probe in a baby that's moving with his arm down, I'm not going to get good alignment and my image quality will suffer. But if I get the nurse to contain, and we're going to go through this, and abduct the arm, actually this allows me to align the probe better in a direction that I want to do without the baby being upset, angry, and really that'll give me better image quality because of the nature of how I'm using the probe with good alignment, good apposition, and keeping that apposition at a level where the sound waves will be incident at 90 degrees and give me the best characteristics. Okay, so we have a question from Marwa. Go ahead, Marwa, unmute yourself.
Well, hello, Dr. Alok. I understand the concept of increasing the frequency to decrease the penetration and the reverse, but I just got confused. What does the focus has to do with this? Like most of our machines, we need to change the focus if we need to look at one sector with better quality. But if I change the focus, this means that I have to change the frequency of my probe. I just got confused with this.
No. So it's a lovely question, and it's important that we focus on it. So as I said, machines that we used in yesteryears would help you to change the focus. So a simple example is I'm going to go back to that image that we have. Now this is pleura. So I'm just going to use my cursor, laser pointer. This is pleura, and this is my area of interest. Now over here, you basically have tissue. Sorry, my apologies. Just doesn't like my ink color at the moment. Oh. So this is the image that I'd like to show you. So can you see at this particular point, Dr. Marwa, that you have tissue for sound waves to interact with? But this is 2, this is about 4 centimeters. And really what I want to do is I want to see the pleura moving. So this is my area. Now, old machines would allow you to change your focus up and down along this axis to 2 centimeters, which means the incidence of sound waves would be most reflective at this zone and give you a very clear image.
Yeah.
But with newer machines, what they've done is to give you better architectural quality throughout the image. They have aligned to optimize your focus at every level. So if you use the new GE that we currently have, actually it gives you beautiful images uh, to the point where I can see the structural architecture very well. It tends to try to reduce artifact, which is really the most important aspect of us determining lung ultrasound. And in order to make that image better, really what you might have to do in the newer machines is rather than trying to alter focus, which you can't, you'll have to change the frequency. And we will discuss this because if you say, for example, I'm just giving you this example over here. This is an adult. And in this adult, at this particular point, you have a convex probe with a frequency of 6. And if you just focus on this region, because the sound waves are going to penetrate and interact with this area better, this is much crisper, more aligned. It gives you better resolution. On the other hand, a lower frequency probe gives you more depth. So I can see better over here. I can see much better over here. This is all dropout. So I can see the depth better over here, but look what's happened to my resolution. Now, if I want to focus on lung sliding, Actually, what I want to do is use the higher frequency probe. But if I want to look for deeper areas of the lung, I might want to use a lower frequency. And you can change the frequency of the probe in newer machines. But in older machines, to see the more superficial areas, you might have to change focus. To see the deeper areas, you might have to increase gain or use gain compensation.
Mm.
Okay?
Okay, yeah, thank you.
Any other questions, please? Any other questions? Excellent. So we've talked about absorption, just a few issues that I'd like to describe when it comes to reflection. So reflection basically that is perpendicular and comes back to you in a single line, which is what the machine assumes is specular reflection. But actually, when you have an irregular surface, then what you're going to have is diffuse reflection. Now, this is a very important concept. So if you have normal pleura and the probe is aligned perpendicular, then can you see this is uniform linear pleura? It looks smooth, it moves smoothly. But let's say you have chronic lung disease, or if you have a baby who has a pneumonia, where there is exudate and destruction of pleura, then this pleura is going to become irregular. It's going to get blurred. So rather than having what I would say is specular reflection, you're going to have diffuse reflection. And it's this diffuse reflection which is giving you these irregularities and describing the pleura well. So it's the properties of reflection that actually explain why we might have pleural thickening, why we might have irregular pleura, but more importantly, when you look at lung pathology, all lung pathology as per Daniel Lichtenstein originates from the pleura. So if you see deeper structures that don't originate from the pleura, then from my perspective, you should be very careful that what you might be seeing is purely artifact and or your plane in which you're using the probe might not be accurate. Again, something that we will describe a lot when we do peer review. We've talked about specular reflection, scattering. I'm not going to cover in them. Just another concept again. So when you talk about speckled reflection, naturally, when you have pleura gives you a uniform linear kind of a characteristic. Now, because you have air at the back, naturally sound waves are not going to travel well through air. So when you look at the lung architecture, you don't really see architecture. On the other hand, when you do the brain, say, for example, and you're using a cranial ultrasound probe, the echoes that are scattered, because naturally pleura is straight, but the brain is convex and it has meninges in 3 layers, will produce echoes that are scattered. They'll have diffuse reflection. But not only that, the echo that goes into tissue will have diffuse reflection. And because of that diffuse reflection, you will be able to understand the tissue anatomy better. I.e., when you do brain ultrasound, you can see things in intricate detail. You can see the corpus callosum. You can see, I would say, ventricles. You can see fluid within the ventricles. So you're seeing a lot of anatomy there, as opposed to the lung, where because of this A's interface, you don't see anatomy, but really what you're going to see is reverberation artifact, which is what we're going to talk about now. So that's just speckle reflection, pleura, pleura bright. But actually here it's all over the place, which is why you tend to see tissue structure better. Non-perpendicular reflection we've discussed. It just means the intensity of the sound wave as interpreted might not be as good. Now, why is this so important? So you can imagine that if you have lung tissue and your probe is aligned at exactly the right angle with good contact with the surface, you're going to get the best quality images because reflection which produces your image is going to be best. But the interaction of these sound waves going back means they travel the least distance and your image, depending on the frequency you're using, will be good resolution. On the other hand, if you are aligned in this angle, you're not only are you going to have incident reflection in a non-perpendicular way, but naturally the number of waves coming back to you will have to travel a longer distance. I mean, this area, the waves might not even come back to you and you might have dropout, you might lose. Now, this dropout is because of the way you're scanning. And that is really important for the lung, especially when you're looking at points like the axilla, but more importantly, when a baby is moving. And I cannot emphasize enough, if you're not using containment and you're not using your ultrasound in a manner that is comfortable to the baby. So a simple example is if you press too hard, the baby will retract back. It will be in pain. And that'll actually hamper your image quality because of issues of non-perpendicular reflection. It's just angle of incidence being different. I've discussed this. Now, what I'd like to do is basically discuss the concept of reverberation. Now, reverberation is a concept where as sound waves move in, they interact with tissue. Now, what is important from our perspective is when you look at the pleura naturally causes reflection. It's an echo-bright structure. And because it's reflecting back at right angles with sound having to travel back a shorter distance as compared to deeper in the tissue, you get this kind of bright, echo-bright area which moves with breathing because the visceral pleura slides on the parietal pleura. Now, what happens in reverberation? So in reverberation, you have sound waves that are coming from the transducer. They then hit a structure and the energy interacts with that structure. And if you look at it, that structure then moves. And this concept of the structure moving is called reverberation. So actually, if I just go back, so this pleura, when sound waves are incident to it, will interact with the pleura. So you'll get reflection, which will generate the image. But what will also happen is the sound waves will penetrate and they'll interact, and the pleural layer will reverberate. Now, when this pleural layer reverberates, what it actually does is then produce deeper parallel lines that we call A lines. And this is the way they look. So is there any doubts about this concept? Anybody? You understand what reverberation is? It's very, very important. Please say yes.
Can you please repeat it one more time, please?
Sure. Okay. Now, as I said to you, this is basically the probe. Now, the probe is generating sound waves which are coming through. These sound waves basically hit the pleural surface. When they hit the pleural surface, really what is happening is that the pleura basically starts shaking. There is reverberation. This is what is happening. And that is because the pleura is absorbing energy from the sound waves. Now, when it reverberates, naturally, this reverberation will produce further sound waves that will move down. But we will have a concept of energy use where this will get absorbed, the tissues will interact with it. But this concept is called reverberation artifact. And what it basically means is that what you're seeing at the level of the pleura, I just have to take my laser pointer off. So sound waves incident on the pleura reflecting back give you this bright area over here. But really, what is happening is they're interacting with the pleura and they're causing reverberation, which is producing sound waves that go down. And when those sound waves go down, they cause further reverberation. And this reverberation basically produces A lines. And I'm just going to show you the next image. So I just want to go through the normal lung before we talk a little bit more about reverberation A-line artifact. So what is normal lung? So this is your probe. These are sound waves coming through over here. They're hitting. Now you've basically got ribs over here. So when the sound waves are incident on the ribs, naturally soft tissue over here, sound waves will be able to go through. But over here, they're going to reflect back because bone has a high density, but also because the acoustic impedance between this soft tissue area and this bone is quite high. There'll be maximum reflection in these regions. So sound waves won't penetrate at the back over here. So you will get what are these areas of dropout, which we call acoustic shadow. But the pleura, having interacted with these sound waves, which aren't reflected back, appears bright because the acoustic impedance of this tissue area is very different to pleura. So, your concept, you must be wondering, well, bone is such a good reflector. Why is the pleura appearing more bright than bone? Well, the reason is because you have a significant difference between the acoustic impedance of this tissue fat and the pleura over here. And that is causing reflectivity, which is causing the pleura to appear bright. But what it's also doing is it's shaking the pleura, and that is producing sound waves. And as these sound waves are produced, they naturally interact with each other to produce these horizontal artifacts, which are reverberation artifacts. So you can just assume that there is shaking here, shaking here, shaking here. But because of attenuation of the sound waves and their absorption, these A lines become less prominent as you move in. I kid you not, in neonates, very superficially, you can get A lines that are beautiful. They're all the way through. And there's not much attenuation, especially in extremely preterm babies where the tissue is very superficial. But this is an adult. And what you can clearly see is tissue absorption and attenuation, which is causing these A lines to become better. But normal lung has ribs with acoustic shadows, high reflectivity pleura, and A lines as horizontal artifact, which basically reflects good aeration, followed by these acoustic areas of dropout, which we call acoustic shadows, and the pleura moves. This is essentially normal aerated lung. And we call this the batwing sign. Why is it called the batwing sign? Anybody? I'll give you a bottle of champagne if you can tell me. Anybody?
It actually looks like a bat wing when there are two acoustic shadows, and in between there is a intercostal space and A lines are seen. So it looks like a bat wing, is it?
Okay.
Because of the, I think the wings of the bat is ribs.
So the wings of the bat,
Is ribs.
yeah, and then you
Uh,
have this area where you can see cobright pleura. Okay.
Dolore, yeah.
Yeah. Wrong answer, guys. The reason they call it the batwing sign is because bats basically generate echoes which come back to them. So when they actually coined it, it had nothing to do with the appearance. They just called it the batwing sign because the bat uses acoustic ultrasound to kind of communicate. But actually, somebody then put his brain together and basically then decided that, well, let's give it the appearance as well. So when Daniel Lichtenstein initially kind of described the batwing appearance, it was all about the fact that bats basically generate ultrasound as opposed to the actual image. But what is the batwing sign? So let's talk about it in a little bit more detail. So this is just a nomogram. And in this nomogram, what you can see is skin. You can see ribs. You can see muscle in between the ribs. And then you see this blue area, which is pleura. And you have aerated alveoli at the back. Now, naturally, when you have alveoli, you also have interstitial space in between. So the alveoli basically, with the interstitium where blood vessels go, have gas exchange. And the interstitium basically, again, has tissue, which is soft tissue. So it may be filled with fluid, it may not. Normally, there is minimal fluid in the interstitium when the lung is well aerated. But let's see how the batwing sign is generated. So your ultrasound waves basically come in from the ultrasound machine. They pass in between the tissues. Now, naturally, when they interact with ribs, they get reflected back. So if we just look at how they reflect back, they'll reflect back off bone in a much better way. So you're going to get an acoustic shadow in this region because actually there's not much sound going in this region from the ultrasound waves. On the other hand, if you look at regions between, you kind of tend to have sound waves reflecting back to produce and give you the appearance that they do. But more importantly, they're able to interact with the tissue there. And if you look at the pleura where the reverberation artifact is created, naturally, this will travel between these areas because there's no bone. But what you get is this area of acoustic dropout with the ribs. This gives you the wings of the bat. And this area of brightness that you see, which is technically the pleura, because you have more reflection back from the pleura, is really what we call the batwing sign. So that's your batwing sign for you. Rib, acoustic shadow, and then bright pleura. And this is the way it looks. Rib, acoustic shadow, pleura. So theoretically, somebody has basically decided that actually this is what you call the batwing sign. And this is how it's generated. And it's basically because the ribs tend to reflect back. What are A-lines? A-lines are basically reverberation artifacts. Now, again, I'm just giving you an example here. This is a convex probe. And what do you think the frequency of this probe is? High or low? Anybody?
Hi.
Hi.
You sure? It's
It's
10
nice.
centimeters.
Low.
It's 10 centimeters. You can see all the way to the back.
Yeah.
Low.
What did we say about low frequencies? They travel a greater distance and a greater wavelength.
Ah, yes. Mm.
So this is going to be a low frequency probe. This is a low frequency curvilinear probe in an adult. Now, I just, again, want to kind of describe that even in low frequency probes where the footprint is small, what you get, and you can see reverberation artifact, that's pretty decent all the way through. So the pleura is reverberating because of the sound waves, and that is getting transmitted down. So I'm just giving you an example of how even using a curvilinear probe, you can generate an A profile or a normal lung appearance. So just going back to the normal lung appearance again. So what is happening over here is that rather than using a linear probe, which is incident to it, we're using a curvilinear probe over here, but it's still giving you reverberation artifacts. What is this reverberation artifact? So we just describe it again. Ultrasound waves causing reverberation at the level of the pleura. And really, from our perspective, that reverberation is then getting transmitted because of the way it interacts. But because of absorption and attenuation, you find that the sound waves, basically from our perspective, are trapped in these areas. They interact with the tissue in these areas. And because they interact in the tissue in these areas, there is attenuation, there's absorption. And these A lines might actually decrease in their actual intensity as you go down, as you can see in the previous image. Okay, we have a question. Yeah, go for it.
Which zone of the lung are these A lines being created?
Okay. Okay, let's just change our probe very quickly. So the A lines basically are because of interaction of sound waves with the level of the pleura. So when they interact with the pleura, naturally they will interact with the pleura and cause the pleura to shake. Now, if anything shakes, it's also going to produce sound waves. So those sound waves are going to then propagate in. But as I've kind of shown you in this particular image, they're trapped. And the trapping basically of them in this particular zone means that this reverberation just carries on as you go lower down. But because of absorption and because of the process of attenuation, the A lines look less prominent as you move down. They are actually being created at the level of the pleura. Does that make sense?
So yes, the ones above, obviously, you can say, yes, I understand it's the pleura, but as it goes down deeper, is there like what I mean, that tissue has to be,
no,
the tissue content has to be.
That's not tissue, that's artifact. You're not really seeing them. This
Okay.
is really important. This is artifact. So it's not as if there's tissue there that's causing this. So a simple example that I'd like to say is, have you ever dropped a rock straight down in a pond? Have you seen the ripple effect?
Yes.
And I'm going to show you the ripple effect with the next talk when I give it next week. So the ripple effect basically means that those waves that go out, can you see how they go out?
Yeah.
They're actually energy. They have nothing to do with tissue. And this is exactly what's happening at the level of the pleura. This is energy that's basically being dissipated and getting less and less and less. And it's because of the way the sound waves interact with tissue, but it's not actually tissue, it's artifact. Does that make sense?
Yes.
So it's not really there. And it's very important when it comes to trying to diagnose a pneumothorax.
Thank you.
So again, just an example of what is happening. So this is the probe, this is the transducer. Sound waves coming through, reflecting back from the pleural surface. Naturally, because of the difference between acoustic impedance between the soft tissue and the pleura, the reflective surface of the pleura is bright. But really, what is happening is this pleura is naturally shook by the sound waves. It's creating reverberation artifact. And as you go down, this reverberation artifact basically becomes less and less. So it's a little bit more bright over there. Here, it's less bright over here. It completely disappears. And it's similar to that ripple effect you see in the pond. You drop a rock in, basically the waves go out and out and out, but they actually become less prominent as you go out. And this is what is happening. These are basically your A lines, parallel A lines. And here actually they look pretty prominent, but they are reverberation artifact. They are not tissue. They're not visible tissue. A normal lung will have, fully aerated lung will have normal A lines reverberation artifact with a batwing sign. Now, how are B lines generated? And we will talk about this and then finish, because I'm conscious we've gone beyond our time, but this is a very important concept, is when sound waves are generated in the lung, really what happens is that this is the pleura. These are the rib spaces, which have acoustic shadow behind them. But in between, you have, as I described to you, so sound waves going through. Now, I told you there's an interstitium. And in this interstitium, what happens is, depending on the amount of fluid involved, you have basically fluid arranged in tetrahedron bubbles. Now, these tetrahedron bubbles, thousands and thousands of them, will, from their perspective, get sound waves in between them trapped. And the sound waves are trapped in such a way that they can't come out. Now, because they're trapped in such a way as they can't come out, forget this image. We're going to look at the next one. Really, the sound waves being trapped in them and them being arranged in the interstitium will cause vertical reverberation artifacts. And what does that look like? So this is just an example of the sound waves coming through. So they hit the pleura, but you have fluid in the interstitium. And because of fluid in the interstitium, these sound waves basically are stuck, and they're infinitely stuck between the tetrahedron. Now, because they're stuck within the tetrahedron, rather than creating these horizontal A lines, they completely obscure the horizontal A lines, and you get these bright areas of vertical reverberation artifact. And these reverberation artifacts are basically called B lines. Why are they formed? Because sound waves incident in these tetrahedrons are basically stuck, and they're causing this area of the lung to basically shake. And if it shakes in a kind of a linear way, that shaking is then interpreted by the prone as a vertical line that extends all the way down. And this is called a B line. These are what B lines look like. So again, these vertical reverberation artifacts, again, what you must understand is this is not the structure of the lung. This is artifact. But what the B lines basically reflect is interstitial fluid. And you can see them coming all the way down. And we'll talk about what's normal and abnormal in a baby in the next class. But what, from my perspective, is very important is that as fluid accumulates, and if the alveoli get full of fluid and these B lines get very, very wet, and a classic example is babies who have very severe TTN, then eventually the B lines will coalesce together. And if the alveoli are full of fluid, then sound waves basically get trapped completely and you get whiteout lung. So as B lines progress, there can be compact B lines, there can be alveolar interstitial edema, and then there's white lung. And this is classically what it looks like. So here you've got B lines, you've got pleural sliding, but you've got these B lines. But what has happened is the alveoli are also full of fluid. So because of that, you see no aeration, you see no A lines. Now, theoretically, B lines will break A lines, but it's very theoretical. And depending on aeration of the lung, you can have various levels of interaction. And that is reflected here. So really what you've got over here is normal lung. So we're focusing on here. Forget the pneumothorax, forget everything else. So when you look at the normal lung, sound waves are incident. They will naturally get reflected back. You'll have acoustic shadow behind the ribs, but they'll interact with the pleura, which is bright. And because there's aeration of the alveoli, there's air coming in and out, alveoli collapsing and moving, that will cause the visceral and parietal pleura, if you look at my hands, to move over each other, and that produces lung sliding. But more importantly, because they interact with the pleural margin, they will create horizontal reverberation artifact, which will move down. Now, we all know that in babies who are born, there's a certain amount of fluid, and actually fluid persists for quite a long time. We'll talk about normal transition, but really there is an element of air fluid ratio, and well aerated lung, normal lung, will have 98% air and very little fluid in the interstitial space, just 2%, which is why it looks completely aerated. Now, as soon as you start getting more fluid in the interstitial space, what happens is the sound waves that are incident create vertical reverberation artifact as compared to the horizontal reverberation artifact. It breaks down the A lines so that only B lines are visible. Now, naturally, if the alveoli are full of fluid, then actually there's virtually no aeration of the lungs, which kind of means that you have a very high fluid to air ratio in that situation. And that is called interstitial syndrome. And really, what they talk about is it's just 5% fluid that's needed to actually produce interstitial syndrome. I'm not going to talk about pleural effusion pneumothorax today, but what I'd like to talk about is just the last thing, and that's consolidation before we finish. So on the right over here, you can see consolidation. Now, naturally, there is rib shadow over here that you can see. Can't quite see it over there because this is an adult. There is pleura. Now, this is parietal pleura, vessel pleura. There's fluid. Now, I did mention that when ultrasound waves are incident, they'll reflect back from the pleura. It doesn't look very bright over here because the acoustic impedance between the soft tissue and the pleura here is not very great. Now, that could be because of how the probe is being aligned. Maybe you don't have good contact. In particular, I'm really worried about this area in your contact because you have complete dropout right from the top. So maybe the pleura doesn't look very bright over here. This is parietal pleura. But then you have fluid. And you remember what I said about fluid? So sound waves will move through it in a very uniform way. And that kind of creates this anechoic area because naturally there's nothing in the fluid that separates two layers for them to kind of reflect back. But what you will find is that when you have consolidation, these areas of tissue, and I'm going to draw it out for you so that you can get it. So I've got an area here. Sorry. Why is my pen working? I've got an area here that basically is quite irregular because it's been destroyed by infection. Now, because it's been destroyed by infection, you have exudate, you have air that's not getting into this particular area over here. So the lung has collapsed back from the pleural margin. And really, from our perspective, the lack of aeration basically means that the tissue between which is destroyed will have a lot of diffuse reflection as opposed to specular reflection. Now, if it was specular reflection, you'd have echo-bright pleura. But because there is diffuse reflection, which I told you is better to see tissue appearance because of the individual tissue cells, you will get a tissue-like appearance. And this is classically how consolidation presents. Okay? So we're basically going to stop there and we're going to open the floor to any questions because this is what I want you to take home today.
Can you just explain about this consolidation again? So,
Okay, so what I'd say from my perspective is that it's really frustrating that the pen is not working today. I don't know why. It's just not letting me draw. So if you look at the consolidation over here, consolidation is an area like this is mnemonic kind of clinical presentation. Take my word for it. Based on clinical correlation. Now you have pleura. This is parietal. This is visceral pleura. And you basically have lung that's compressed. But what has happened over here is you've got an infective process that's destroyed lung tissue. Now, because it's destroyed lung tissue, air can't get into this area. Now, if you can't have air in this area, are you going to get A lines?
no.
Okay. So you have to get some appearance. Sound waves are still going to move in. Now, sound waves are going to move in and interact with this tissue. They naturally are going to bounce off the parietal pleura. They're going to bounce off the visceral pleura. Now, here, my argument would be that parietal pleura should be relatively echo-bright, but I think because of the way the probe is aligned, you're not. But here, naturally, you're getting an echo-bright area because the sound waves traveling through fluid are reflecting back. But because there's no air over here, there's a lot of tissue that's damaged. Sound waves that were previously normally just incident in a specular way, that go back perpendicular, are basically going back in a diffuse way. And if you remember what I said, when there's diffuse reflection of sound waves, that tends to give you tissue architecture better. So you're seeing tissue architecture better here because of diffuse reflection. The absence of air means you can't get A lines. And really, there's no fluid in this area. It's consolidation. So really what there is tissue. There is fluid in this area over here, which is why you're seeing a B line come back. So there is vertical reverberation artifact, but not in this area. And this is consolidation for you. If you go back to the previous slide, this is what it's going to look like. This tissue has been destroyed. These alveoli are no longer filled with air. They may be filled with exudate, but the reflection over here, rather than being perpendicular and going back, is diffuse. It's air trapped, and that is basically causing consolidation. What we say, naturally, I said, there's not going to be air there. So the ratio of air to fluid is less than 10% in consolidation. Okay?
Okay.
Any other questions? Yeah.
Yes. So all lung pathology now depended on the air fluid ratio, right?
Theoretically, yes.
Yeah. About consolidation is direct image, not artifact.
Yes, in this case, it's the interaction with anatomy which is producing your consolidation. But different types of consolidation atelectasis, and I'll describe how to kind of differentiate the two, is all about the interaction of the ultrasound waves with different areas of lung. So you can get consolidation that this looks basically hypoechoic. You can get areas of consolidation that look hyperechoic as well, depending on how the sound waves are interacting. Again, if you have consolidation in this area, which is just adjacent to pleura, I mean, this is also consolidation, but it's echo bright. And I'll explain why when we do consolidation. But I hope it makes sense. Any doubts, please do not leave this session with doubts. My humble request to you is that I will be sending you a few articles to read and one very nice video to watch on YouTube. There was no point in me plagiarizing that video. It's beautiful. It gives you really good kind of, I would say, 20 minutes of lung ultrasound physics, but it's a very nice video. Questions, please.
I'd like to ask questions. I think it is out of our scope in this session, but in this slide, there is a pleural effusion. Is that right?
That's correct.
And the other, I'd like to ask also, what is the Schritt sign? What's the Schritt signs mean?
We'll cover it going forwards. For today, leave it because
Okay.
it'll confuse people. I'll cover the ultrasound physics of it as well. Yeah.
Thank you.
My apologies. Yeah.
Hello, can I ask a question, Alok?
Yeah.
Yeah, see, just to get a clarification. So if we have air in the lungs,
Yeah.
the reverberation artifact is clear. That's why you see the air lines.
Yep.
If there is no air, there is no reverberation. That's why you don't see air lines. But because of there is a liquid, they get vertical trapping of the ultrasound waves. That's why you get the B lines.
That's correct.
Okay. Thank you.
Okay. Anybody else? Surjit?
So the pleural line which we see, is that the parietal pleura which we normally see?
That's parietal pleura over here. That's visceral pleura. It's only visible when you have fluid in between.
No, sir, in a normal lung, when there is no
You won't be
fluid,
able to see. You won't be able to see the difference. There has to be fluid to be able to differentiate. Normal lung will appear as just one echo bright region of pleura. But
is that parietal or like?
no, that's just pleura. You
Just
cannot
pleura.
differentiate the two. It's just pleura. Okay. Any other questions before I move to questions in the chat? Just looking. What is the difference between B line and commence as mentioned? Satish, do you want to just ask your question again? Because I don't quite get it.
Yes, sir. You are mentioning about the comets which confuse with the B lines.
Yeah. So we're not talking about comets today. No, forget about it.
Okay.
We're not talking about comets today. Again, you're coming to the concept that ring down artifact. So there are at least three theories behind the production of B lines. Some people basically say that ring down artifact and comet tails have a completely different way of being produced, and it's not related to the tetrahedron. So we're not covering that today. We will cover that in the next class, please.
Okay.
Yeah.
Okay, sir.
Okay. One last question before I take you through logbooks.
So what is this tetrahedron? I didn't get it. It's like, why is it that word used?
Sorry, my apologies. So can you see the image on the left side?
Yes.
So fluid is organized in the interstitial space over here in the form of these small fluid bubbles. This is the theory behind it. These are tetrahedrons. They're in groups of 4 each. Now, because they're in groups of 4 each, a sound wave that comes through basically bounces off and infinitely kind of goes between the tetrahedrons. Now, naturally, if the sound waves are stuck over here, there's going to be energy over here. Now, because they're organized vertically in groups of 4, they're going to cause shaking. And rather than horizontal ley lines, the shaking is going to be vertical. So if I say to you that that is multiple bubbles over here, all as tetrahedrons, it's shaking along this entire column. And this is the theory behind how B lines are created. I would like you all to read the article that I sent to you by Patricia Wood. It's very good and it gives a very nice explanation of how that happens. But we'll cover it again, so don't worry.